disorders. Number 2, papillosclerosis disorders. Number 3, histamine-related disorders. And number 4 is eczema. Let us first start proceedings with pigmentary diseases. Let's look at the question. Name the amino acid from which melanin is derived. The correct answer for this question is tyrosine. Tyrosine is the correct answer for this question. Now, let us look at the disorders of hyperpigmentation only. So, disorders of hyperpigmentation, first we have melasma. Now, melasma is defined as an acquired hyperpigmentary disorder. The important triggers for it include sunlight, thyroid dysfunction, and pregnancy. So, please remember when we learn the chapter of physiological changes in pregnancy, what we see is in a pregnant mother, when there is pigmentary changes which can happen over the face, it is chloasma. So, the word chloasma means mask of pregnancy. Next, we want the clinical features. How is the patient going to present? You get symmetrically distributed hyperpigmented macular lesions on the malar area, nose, and the mandibular areas. One important point in relation to melasma you need to remember here is that melasma-like pigmentation of the nose has been reported from India, and this pigmentation, which is seen on the nose secondary to chikungunya fever, is called ginseng. This is an important point to remember. Next, we go on to the second disease, which is freckles. In freckles, melanocyte number is normal, activity is more, and freckles are generally associated with xeroderma pigmentosum. So there's a genetic disorder called xeroderma pigmentosum, where you get freckles. So you can see this multiple hyperpigmented macular lesions where the number of melanocytes is normal, activity is more. It is generally seen due to sunlight exposure. The third disease in this chapter is going to be called as lentigenes. In lentigenes, it's exactly the opposite of freckles, students. So please remember, here the number is more, activity is normal. So you can see this multiple hyperpigmented macular lesions. Number is more, activity is normal. Now we look at a syndrome which is autosomal dominant in inheritance as mucosal lentigenes. So we can see the presence of multiple hyperpigmented macular lesion, and that's called GI polyps. Please remember this point that GI polyps which you get in this condition are hematomatous in nature. Hematomatous polyps. They are hematomatous polyps, and these three important features are suggestive of Peutz-Jeghers syndrome. This is suggestive of Peutz-Jeghers syndrome. Next, we move on to the fourth topic of congenital melanocytic nevus. Now, what is this condition, students? This is characterized by benign proliferation of the melanocytes, which starts from birth itself. How do I identify this lesion? So you can see this lesion is hyperpigmented. Number 2, it has well-defined borders, so that is also not a problem. Very, very important is it is hyperpigmented, well-defined borders, and you can see the presence of multiple hair strands on the surface, so it becomes hypertrichotic. So hyperpigmentation, hypertrichosis, and starting from birth itself, diagnosis becomes congenital melanocytic nevus. However, one thing we need to remember, if the size is more than 20 centimeter, then what you should remember, this is called as giant congenital melanocytic nevus. Now, why we should remember about this condition? Because this condition has a 2 to 5% risk of transformation into melanoma. Very important point, students. Please remember, if the size is more than 20 centimeter, always keep the child under surveillance because it has a 2 to 5% risk of transformation into melanoma. Next, we move to the fifth condition under hyperpigmented disorders, which is Becker. Please remember that congenital melanocytic nevus is congenital; it starts at birth, whereas Becker's nevus is an acquired condition. So this is an acquired condition. Point number 2 is unilateral. Point number 3 is hyperpigmented. It's hyperpigmented. Point number 4 is hypertrichotic. Point number 5, chest and upper shoulder. So these are the 5 points how we identify a Becker's nevus. So it is acquired condition, unilateral, hyperpigmented, hypertrichotic. Chest and upper shoulder are common sites for Becker's nevus. Next, we move to dermal melanocytosis. What does it mean? It means there is melanocyte proliferation at the level of the dermis here. And always remember, students, when the melanocytes start proliferating in the dermis, the color of the lesion is going to be blue to slate gray. It is going to be blue to slate gray. And those diseases in dermatology which have a slight bluish color appearance, we call them as ceruloderma. So the word cero means blue. Now let's take up the first dermal melanocytosis. So we can see here it's an infant who is presenting with these bluish macules and is mainly distributed on the lower back. What should be a diagnosis? Very easy question. We see infants on routine examination. This is called as a Mongolian spot. So this is a Mongolian spot. Very, very important point. It usually resolves spontaneously. Next, we move on to nevus of Kota. So under dermal melanocytosis, we have covered number 1 is Mongolian spot. Number 2 is nevus of Kota. So nevus of Kota is a unilateral condition. Number 1. Number 2, the color of this condition is also blue to slate gray. And very important is the nerve that it traverses. So it is going to follow the first and the second division of the trigeminal nerve. So the distribution pattern is along the first and the second division of the trigeminal nerve. So here you can see this is the first division and the second division of the trigeminal nerve. So obviously, since it's involved in the trigeminal nerve, you can involve the face, and it involves the sclera in 2/3 of the patient. So this also becomes important to remember. The third and the last condition under dermal melanocytosis is nevus of Ito. Now, nevus of Ito is also a unilateral condition. It is also blue to slate gray color, but the nerves are different. So here you have the posterior supraclavicular nerve, posterior supraclavicular nerve, and second one is lateral brachial cutaneous. Lateral brachial cutaneous. So posterior supraclavicular nerve, and this is the brachii or the arm, lateral brachial cutaneous nerve. When these two nerves get involved, obviously the distribution is going to be on the shoulder and the scapular area. So this is a blue color lesion. Looks very similar to Becker's nevus, but please remember, Becker is seen later on in life, and it is hypertrichotic. You get hair on the surface. Ito is blue in color. That's how we distinguish between nevus of Ito and Becker's nevus. Now let us look at the disorders of hypo or depigmentation. So first we look at albinism. Now albinism is a condition where the defect is going to be at the level of tyrosinase, the enzyme which is responsible for melanogenesis. You have two types of albinism, students. Number one, when only eyes are involved, we call it as ocular albinism. Then eyes are involved, skin is involved, hair is involved, we call it as oculocutaneous albinism. In this context, let us look at a case-based scenario. So this is a child who presents with oculocutaneous albinism, has a recurrent infection and has gone to the pediatrician now. The pediatrician asks for a peripheral smear, and on peripheral smear, what do you see? You see giant granules in the neutrophil. So if these 3 points are given in the exam, straight away mark your answer as Chediak-Higashi syndrome. So this is Chediak-Higashi syndrome, which is an autosomal recessive condition. This is point number 1. Point number 2, it involves the List gene. And point number 3, what is the defect over here? The defect, phagolysosome fusion. Is defective phagolysosome fusion, which is happening in Chediak-Higashi syndrome. So phagocytosis is defective, due to which what is going to happen is the child gets recurrent infections, and look for this giant veins in neutrophil. This is also a question in pathology. Next we move on to piebaldism. Now piebaldism is a autosomal dominant condition. The defect over here is at the level of the neural crest. So we already have learned in the basics chapter that the melanocytes are going to come from the neural crest. So neural crest itself is not working here. So what is going to happen is you are going to get a triangular depigmented area. So you can see the triangular depigmented area on the forehead. You get white hair over here. Okay, the patch is white and hair from it is also white. This lesion is referred to as white core lock. So it is white, that's why it's called white. It is located on the forehead, that's why it's called fore, and lock means bunch of hair. So how does the patient present over here? You get a white color bunch of hair coming from the forehead from a triangular area on the forehead. This is a characteristic presentation of piebaldism. Next we move to nevus depigmentosis. Now nevus depigmentosis is a congenital, non-progressive, stable disease. So you can see this characteristic serrated margins. You get a little bit of serrated or feathery margins. You get serrated or feathery margins in this lesion. What is the pathology over here? Usually what happens is one melanocyte will give its melanosomes to how many keratinocytes? 36 keratinocytes. This we call as epidermal melanin unit. So one melanocyte is giving its melanosomes to 36 keratinocytes. This is called as epidermal melanin unit. So here what happens in nevus depigmentosis, this is not functioning. The melanocyte is not able to give its melanosomes to the surrounding keratinocytes, due to which you get nevus depigmentosis. Next we move to nevus edematous. So here we can see some whitish lesions over here. So usually you think whenever it's so white, it's probably a disorder of the say this is an exception, students. So please remember, what is this condition? It is a congenital white patch of vasoconstriction. So what will happen is, because there is vasoconstriction,
anemic vascular problem.
Receive less blood supply. It will receive less blood supply. And we know what is the physical sign of anemia? Pallor. So once there is decreased blood supply, the color also will become less. So that is why you get hypopigmented lesions. But please remember, nevus edematous is a vascular problem. It is not a melanocyte problem. So this is something we have to remember. Next we go on to the acquired conditions of hypo or depigmented conditions. First we have vitiligo. So how do I define vitiligo? Vitiligo is also an acquired condition. It's a chronic condition. It's a depigmented condition. Very, very important. Here melanocytes are absent from the lesion. Here melanocytes are absent from the lesion. Okay, let's look at the classification of vitiligo. Vitiligo is divided into segmental, non-segmental, unclassified or undetermined type. Let us first look at segmental. Now, segmental vitiligo has been asked twice in your exams, once in FMG, once in Neet PG. The onset of this disease is generally early childhood. There's a question on the progress of this disease, that's why I've highlighted it. So progress is initially it
hello Joseph Edward, hello.
So initially suddenly it increases and then it stabilizes. Exactly the same question was asked in the exam. Which form of vitiligo initially rapidly increases and then stabilizes? The answer for this question is segmental vitiligo. So here, this is a unilateral condition. So you can see the lesions over here. You can see the unilateral distribution of the lesions. This unilateral, it is segmental. It is following a particular segment of the skin, and it does not cross the midline. Very important. It does not cross the midline, and sometimes these melanocytes which are getting destroyed. Not only the skin melanocytes, our hair also has got melanocytes, so that also can be destroyed. So leukotrichia may be present. Leuko means white, trichia means hair. So if you have leukotrichia, that could be an additional feature in segmental vitiligo. Next, we move to non-segmental vitiligo based on the distribution. So if you see that the facial area is involved and the extremities are involved, think of acrofacial vitiligo. So this is part number one. If the mucosas are more than one side getting involved, we call it as mucosal vitiligo. The most common form of vitiligo, that is why the other name for most common in dermatology is vulgaris. So we call it as vitiligo
vulgaris. Non-segmental.
And if the depigmentation process has involved more than 80 to 90% of the body, then we are going to be calling it as universal vitiligo. Then we are going to call it as universal vitiligo. And lastly, there is a type of vitiligo which is classified as unclassified or undetermined type.
Universalis.
Small isolated depigmented lesions. Then we think of a vitiligo called as focal vitiligo. So these are the various types. Let us look at some pictures. So you can see here one patch,
small
vitiligo,
one patch,
focal vitiligo.
One patch only, one
then
patch.
You can see there is one segment.
One segment.
This unilateral does not cross the midline. We want to call it as segmental vitiligo. Then what is happening over here? We have the acral portions of the body and face getting involved.
Acrofacial.
Acrofacial vitiligo. So let's write it as acrofacial vitiligo. And then we have a type of vitiligo which is symmetrically distributed and on both sides of the extremity. So we call it as vitiligo vulgaris. Very important point to identify: bilaterally symmetrical lesions. Bilaterally symmetrical lesions. And lastly, I told you if more than 80 to 90% of the body is getting involved, we call it as universal vitiligo. So these are the various types of vitiligo to keep in mind. So this is some of my clinical patients. So this is the acral vitiligo, which is a little difficult to treat. The vitiligo vulgaris, which is the most common form of vitiligo. And clinically, when you can see this depigmented macule. Okay, I told you in vitiligo, melanocytes are absent. So this is the chalky white depigmented macule. We can add this word chalky white. So please keep in mind, if there's less pigmentation, it is called hypo. If there's more pigmentation, it is called hyper. If there's no pigmentation, we call it as depigmented lesions. And further, you can see there's a trauma in this patient, and after a trauma, you can see multiple white lesions developing here. So this phenomena is called as true cognous phenomena. Very, very important point. And here you can see some hair strands which have become white. So this is referred to as leukotrichia. Always remember, students, that leukotrichia has got a bad prognosis. Why does leukotrichia has got bad prognosis? Because it means that vitiligo has not only destroyed the skin melanocytes, it has also destroyed the hair melanocytes. That means it is a progressive disorder. That's why leukotrichia also becomes a bad prognostic factor. Next, we go to treatment of vitiligo. So number one, we have topically, we have corticosteroids, we have tacrolimus. So for pharmacology, you should remember
tacrolimus.
Calcineurin inhibitor.
Tacrolimus is a calcineurin inhibitor.
That's what we can give. And then lastly, we have phototherapy. Just to revise, 311 plus or minus.
Tacrolimus, corticosteroid topical, systemic steroids and azathioprine, and phototherapy, which is NBUEB, means narrowband UVB 311 plus minus 2 wavelength.
Minus 2 nanometers is going to be the wavelength. Next, we move to chemical leukoderma. So chemical leukoderma means chemical induced melanocyte destruction. Chemical induced melanocyte destruction. In vitiligo, please remember, students, that it is the autoimmune theory. Autoimmune process is destroying the melanocytes, whereas chemicals are destroying the melanocytes in chemical leukoderma. So chemical leukoderma, which is due to bindi, is triggered by PTBP. PTBP stands for
para-tertiary butylphenol. PTPB.
And then in rubber footwear, generally you can see this.
Monobenzyl ether
called as NBEH here. So this NBEH, the expansion goes like this. It's monobenzyl ether of hydroquinone. So this can destroy the melanocytes of the skin, resulting in leukoderma. Next, we move to papulopustular disorders. Now here, first let's take up psoriasis. Now psoriasis is defined as a chronic T cell mediated inflammatory disease, which not only involves the skin, it also involves systems. So when this chronic inflammation happens all over the body, one important question which has been asked in the exam is the association of psoriasis can be with metabolic syndrome. This metabolic syndrome is happening due
Association
to
with metabolic
systemic
syndrome.
inflammation. Systemic inflammation. So please remember, students, that psoriasis is not only a skin disease, it also involves internal organs resulting in metabolic syndrome. Next, the HLA predisposition with psoriasis. So HLA-C, W6. See, whenever we study HLAs, we never come across C. We have heard about B, we have heard about D. C is very, very rare for early onset psoriasis. Early onset psoriasis. HLA-B27 is for psoriatic spondylitis. Psoriatic spondylitis. So these are two important HLAs to remember. Now let us look at the pathogenesis. The epidermis shows hyperproliferation. The keratinocytes are stimulated, they start hyperproliferating, and the dermis shows inflammation. So when you talk about inflammation, you have to remember that TNF alpha, interleukin number 17, interleukin number 23. These are some important cytokines you need to remember which can stimulate the inflammation in psoriasis. And epidermal transit time also becomes important because of this rapid epidermal hyperproliferation. The time taken by the keratinocytes to go from the last layer to the first layer is reduced, and this is just a meager 3 to 5 days. So in 3 to 5 days, the entire transit time is completed. That's why you get a lot of scaling in psoriasis. Now we go to the clinical types of psoriasis. Number one, we start with the most common one. The most common one is psoriasis vulgaris, also known as chronic plaque psoriasis. So how will the patient present over here? You can see multiple erythematous red papules and plaques. So erythematous, scaly, papules and plaques. This is point number one. The scales of psoriasis are very, very important. They're called silvery white scales. It's silvery white scales, and the distribution is predominantly over the extensor aspects of the body. So red, scaly, papules and plaques are important, silvery white scales are important, and then what is important is the extensor distribution of the disease. Now let us look at ospid sign, a clinical sign that we want to demonstrate in psoriasis. So here what do? We take a glass slide and we scrape the lesion of psoriasis. So you can see the image here. The glass slide is taken and we scraping the lesions of psoriasis. When you're doing this particular test, this test is also called as Gottard's test. This test is also referred to as Gottard's test. So what will happen when you take the glass slide and scrape the lesion of psoriasis, students? What happens initially is, number one, you get silvery white scales. This accentuation of the scaling, and you further keep on scraping, then what happens? You get a membrane. This membrane is called as Balkeley's membrane, and further if you keep scraping, you get multiple pinpoint bleeding spots. Multiple pinpoint bleeding spots. So this together is referred to as ospid sign. So here also you can see the presence of these multiple bleeding spots after ospid sign is performed. Let us now look at the clinical demonstration of ospid sign. So what are we doing in ospid sign is we're taking a glass slide and we're scraping the lesion. So here we can see when we're scraping the lesion, progressively the accentuation of silvery white scales are noted. These are the very important silvery white scales of psoriasis. We're continuing to scrape the lesions till we have reflected the last portion of the scale. And once we have reflected the last portion of the scale, now we can visualize the Balkeley's membrane. And once you have visualized the Balkeley's membrane, we continue to scrape it, and we are looking for the end point. The end point of this ospid sign is going to be the visualization of minute punctate bleeding spots, which is clearly visualized as an end result. Next, we move on to Cobnus phenomena. Now, please remember, students, Cobnus phenomena is also referred to as isomorphic response. What is the meaning of the word iso? Iso means similar.
Similar.
Morphic means morphology.
Similar morphology.
So how do I define Cobnus phenomena? It is basically morphologically similar lesions are appearing along the line of trauma over normal skin. That means imagine I have psoriasis on my extremities. What is happening? If I get a trauma, if I get a cut here, what will happen? The similar, morphologically similar lesions will start appearing wherever there is trauma along the line of the trauma. This phenomena is called as Cobnus phenomena, also known as isomorphic response. So we can see in this picture here, very nicely you can see this patient had a trauma. So after a trauma, you can see the appearance of new lesions, and these new lesions are resembling the old lesions of this disease. And this phenomena is referred to as Cobnus phenomenon. Now, Cobnus phenomena, there are three important types. You have true Cobnus, you have pseudo Cobnus, and you have rare causes of Cobnus. True Cobnus happens because of immunological problem. There are three important diseases here. Number one, psoriasis. Number two, lichen planus. Number three, vitiligo. So psoriasis, lichen planus, vitiligo, the three causes of true Cobnus phenomena. Very important, students, please keep this in mind. In pseudo Cobnus phenomena happens because of auto-inoculation. So this is generally seen in viral infections. So you have an infection, you manipulate it, what happens is you are inoculating the organism in yourself, on your skin, along a line. So this can be possible in two important viral infections. Number one, molluscum contagiosum and viral warts. Molluscum occurs, we have Kaposi sarcoma and Terrier disease. Next, we go on to the nail changes in psoriasis. A very, very important point. Please make a note of these changes. Because a lot of nail changes have to be examined in patient psoriasis. We start with the first one. So here you can see the presence of multiple punctate depressions over the nail plate. So if you get multiple punctate depressions on the nail plate, we call them as pits. But what is important in psoriasis is how do you describe the pits? The pits in psoriasis are coarse, irregular, and deep pits. You can see this coarse, irregular, deep pits. So psoriasis is one of the areas of my interest when I work in college. I usually try to subspecialize in one of the areas of psoriasis because it is something like diabetes with multiple manifestations. So coarse, irregular, deep pits are a feature of psoriasis, whereas fine, regular, superficial pits are seen in alopecia areata. And the significance of pitting in psoriasis is this is the most common nail change in psoriasis. The most common nail change in psoriasis is going to be pitting. Pitting is the second nail change. Now what is going to happen in psoriasis is epidermal hyperproliferation. The same hyperproliferation is affecting the nail matrix, is affecting the nail bed. So what
एक मिनट भाई please stay 1 minute. I am back.
you can see abnormal accumulation of keratin below the nail plate. So below the nail plate, you can see keratin getting accumulated there. So since it is below, we call it as sub. If it is below the nail plate, we call it as subungual.
Hyperkeratosis.
Accumulation of keratin, we can call it as hyperkeratosis. So it's not subungual, hyperkeratosis. So again, I want to tell all of you, keep the picture in your mind and then apply your theory. So picture is the most important thing in dermatology, and then the theory sets in. So sub means below, unguis means nail, hyperkeratosis is the accumulation of keratin. So what will happen is the same keratin keeps on accumulating. What will happen? The nail plate will separate from the nail bed. So here you can see this portion of the nail is called nail plate. So this portion is called nail plate, and this portion is called nail bed. So can all of you see here that there is a gap created between the plate and the bed? There is a distal separation of the plate from the bed. This is called distal onycholysis. This is called distal onycholysis. This is change number 3. Moving on to the last change and very important change in nail psoriasis is the presence of this translucent yellowish red discoloration, which you will get under the nail plate basically, and this resembles a drop of oil. That's why it's called salmon patch, also known as oil drop sign. Oil drop sign. So please remember, students, this oil drop sign or salmon patch is a pathognomonic nail change. It's pathognomonic nail change in psoriasis. So please remember once again the 4 important nail changes in psoriasis. Number 1 was pitting, coarse, irregular deep pits. Number 2 was subungual hyperkeratosis. Number 3 was distal onycholysis. And number 4 is oil drop sign, also known as salmon patch. Please keep in mind that the oil drop cataract for ophthalmology is in galactosemia. So try to study like that. Oil drop sign in psoriasis in dermatology, and oil drop cataract in the eye is going to be for galactosemia. Next, now let us look at the second type of psoriasis. Now this psoriasis is talking about a child with history of sore throat. Now we know sore throat is generally triggered by group A beta hemolytic streptococci, which generally is implicated in pharyngitis. So this is implicated in pharyngitis, and after that what is happening is this is triggering the presence of multiple raindrop-like erythematous scale lesions in the trunk. So if the person comes in exam child with history of sore throat and development of raindrop-like lesions on the trunk, straight away mark your answer as guttate psoriasis.
Child, child, pharyngitis history, raindrop lesion. Child with pharyngitis history and raindrop lesion is equal to gutted psoriasis.
When asked in the exam, what is the meaning of the word gutta? Gutta means raindrop.
Raindrop.
Gutta means raindrop. So just by looking at the term, you can guess the correct answer as guttate psoriasis. Next, there is this third type of psoriasis, wherein the psoriasis patient presents with sudden onset of pustules. You can see sudden onset of pustules, and the patient is febrile. So, psoriasis patient with multiple pustules and fever, diagnosis becomes pustular psoriasis. So this third type of psoriasis, students, please remember, this is called as pustular psoriasis. Now, for pustular psoriasis, please remember the most common trigger is, especially we know in psoriasis, we should never give systemic steroids. So this is usually seen with the sudden withdrawal of systemic steroid to get pustular lesions. How will you identify this in the exam? So when the examiner tells you, so psoriasis patient with multiple pustules and fever, diagnosis becomes pustular psoriasis. So this is the third type of psoriasis, students, please remember, this is called as pustular psoriasis. Now, for pustular psoriasis, please remember the most common trigger is, especially we know in psoriasis, we should never give systemic steroids. So this is usually seen with the sudden withdrawal of systemic steroid to get pustular lesions. How will you identify this in the exam? So when the examiner tells you there is basically going to be lakes or sheets of pus kind of a picture. So patient presents with, initially there will be separate pustules and then they coalesce to form larger collections of pus. If lakes or sheets of pus is given in the context of psoriasis, the examiner is hinting to us pustular psoriasis. You can see a lot of pustules in this patient of psoriasis. This psoriasis patient was given systemic steroids inadvertently and suddenly stopping, resulting in these manifestations. So pustular psoriasis, if you look at the classification, it has two important forms, the acute generalized form and the pregnancy form. The acute generalized form, we also call it as one Zumbush type. We call it as one Zumbush type. And the one which is seen in pregnancy, pustular psoriasis of pregnancy, we call it as impetigo herpetiformis. We call it as impetigo herpetiformis. So please make a note, students, this is a very, very important question. Impetigo herpetiformis is pustular psoriasis of
One
pregnancy.
Zumbus and the
Full type
impetigo
of psoriasis, and here we can
herpetiformis.
see this is a patient of psoriasis who is presented with erythema pictorial scaling. You can see the skin of this patient. This patient has got erythema pictorial scaling involving more than 90% of the body surface area. Then we call this condition as erythroderma, also known as exfoliative dermatitis. Erythroderma, also known as exfoliative dermatitis. So please remember the meanings of this word. So erythro means red, derma means skin, exfoliation means stains. So there is scaling, there is erythema, but the involvement should be more than 90%. Then we call it as erythroderma, also known as exfoliative dermatitis. And lastly, we now move on to the fifth type of psoriasis, it's called psoriatic arthritis. This psoriatic arthritis is a type of seronegative arthritis. We know that means here RA factor is going to be negative. RA factor is going to be negative. The classical joint where psoriasis involves is the distal interphalangeal joint. So we see in the picture the involvement of the distal interphalangeal joint. We quickly revise the types of psoriasis. The first one was plaque psoriasis, where
Plaque
it is the most common form.
psoriasis.
Second, we had guttate psoriasis,
Gutted,
a child with history of sore throat and raindrop
raindrop
lesions with
lesion.
guttate. The third one would be pustular
Pustular
psoriasis, sudden withdrawal of
psoriasis.
systemic steroids in the patient of psoriasis with pustules and fever. The fourth form is where more than 90% of the body has erythema with nerve scaling skin.
Exfoliative dermatitis. Psoriasis, skin, systemic involvement, HLA, Cricket World Cup 6, CW6, epidermis, hyperproliferation, epidermis transit time is 3 to 5 days, dermis inflammation, increased TNF alpha 1723 IL, chronic plaque psoriasis, any other, but great test is a Auspitz test, greatest test, Kobner's phenomenon positive, ciliary white scales on extensor surface, Kobner phenomenon is day type, true Kobner, pseudo Kobner. In true Kobner there is psoriasis, lichen planus and vitiligo. In pseudo Kobner there is molluscum contagiosum and white viral warts. Rare causes are Kaposi sarcoma and Darier's disease. Nail changes in psoriasis, 4 type of nail changes. One is multiple punctate depression, then is the subungual hyperkeratosis, separation of nail bed from the bed, and oil drop sign. Oil drop in the cataract we see in galactosemia. Gutted psoriasis is the second type. Child with history of pharyngitis, child history of pharyngitis with raindrop lesion, we get gutted psoriasis. Pustular psoriasis is like a sudden onset pustules plus fever plus lakes and sheets of pus. Types acute generalized form is von Jumbus, acute generalized, and pregnancy impetigo herpetiformis. Erythroderma is fourth. Erythroderma means red skin or exfoliative dermatitis. Psoriasis erythema plus scaling of 90% of body surface area. Then is psoriatic arthritis. Seronegative arthritis, rheumatic arthritis, factor negative.
And lastly, we have psoriatic arthritis with a classical joint DNT involvement. Let's now move to the histopathology of psoriasis. In histopathology, number one, a thickening of the stratum corneum is called as hyperkeratosis. This is point number one. Normally, I have told you that nucleus is absent in the stratum corneum. If there is disorganized keratinization, you can get nuclei in the stratum corneum. This is called as parakeratosis. You will also get collection of neutrophils forming a collection in stratum corneum. This is going to be referred to as Munro's microabscess. Very, very important.
Munro's microabscess, yes. Munroma neutrophils.
Then this thickening of the stratum spinosum, which we call as acanthosis. One more collection of neutrophils can be there, which is seen in the stratum spinosum. This collection of neutrophils,
Spongiform pustule of Kogoch.
this is referred to as spongiform pustule of Koyo or Kogo. Very, very important. Munro's microabscess is stratum corneum, and spongiform pustule of Koyo is at stratum spinosum. And what else can you see is you can see the retail ridges here. So we know that the epidermis goes into the dermis by means of retail ridges. Dermis projects into epidermis by means of dermal papilla. So these downward projection of epidermis will start showing elongation. So you can see the regular elongation over it. This is called as regular elongation of the retail ridges. And in the dermal papilla, so this area, as I mentioned to you just now, this is called as dermal papilla. The multiple dilated blood vessels. So these are the multiple dilated blood vessels of the dermal papilla. So here you can see the picture, you can see that there is a collection of neutrophils over here. So collection of neutrophils in the stratum corneum, this is referred to as Munro microabscess.
This collection is
It's called Munro's microabscess. Let's now move to the treatment options in psoriasis. So basically we have three types of treatment. Number one, we have topical therapy. Topical therapy we generally give if less than 10% is in.
Topical.
Then we have phototherapy, if more than 10% is input. And we give aromatic therapy, 311 plus or minus 2 nanometers. We use systemic therapy with more than 10% is input. So everything depends on your body surface area involvement. Now, it is with systemic therapies. In systemic therapies, we mainly have methotrexate and cyclosporine. Methotrexate is a dihydrofolate reductase inhibitor, and cyclosporine is a calcium inhibitor. So important side effects to remember of methotrexate is a hepatotoxic drug. Cyclosporine is a nephrotoxic drug. Methotrexate can produce bone marrow suppression, and it also has teratogenic side effects. Cannot be given in pregnancy. One more important side effect to cyclosporine is hypertension. So hypertension, nephrotoxicity for cyclosporine, bone marrow suppression, hepatotoxicity, teratogenicity is for methotrexate. Next thing is in which forms of psoriasis you can use. Methotrexate is generally used in plaque psoriasis, in erythrodermic psoriasis, and you have in psoriatic arthritis. Whereas cyclosporine we generally prefer it in severe erythrodermic psoriasis because cyclosporine is a rapidly acting drug. It is known for its rapid action in psoriasis. Let's now move to first line treatments in special situations. First we have pustular psoriasis. The first treatment of choice is acid retin. Acid retin. Please remember whenever the word retin comes, it must be a oral retinol. It must be a oral retinol. Acid retin is an expensive drug. If it cannot be given due to any reason, the second drug of choice is methotrexate. Now, what do we do in pustular psoriasis of pregnancy? I've already told you students, pustular psoriasis of pregnancy is also referred to as, what is the name I mentioned to you? Yes, I mentioned impetigo herpetiformis. I mentioned about impetigo herpetiformis. So, in pustular psoriasis of pregnancy, we cannot give acid retin because it is teratogenic. We cannot give methotrexate, it is teratogenic. We are not left with many options. So, the only place in psoriasis where you can give systemic steroids is pustular psoriasis of pregnancy. Why are we giving systemic steroids? Because there is no other option. The second drug of choice, which is not mentioned in the exam, we go for cyclosporine. So these are two things which you should keep in mind. Next, we go to biologics. Now, biologics are drugs which act at a particular target. So, if IL-12 and 23, I already mentioned to you that interleukin-23 can promote inflammation in psoriasis. The drug which can target IL-12 and 23 is
ustekinumab.
Okay.
For
The drug which can target
ustekinumab.
interleukin-23 is ustekinumab.
Infliximab,
Then
etanercept,
there are three important drugs which are TNF alpha inhibitors like infliximab,
etanercept,
and adalimumab. So infliximab, etanercept, and adalimumab. And lastly, we have the interleukin-17 inhibitors in the form of
17A.
and ixekizumab.
Ixekizumab, secukinumab.
So this will finish off the biologics which we use in psoriasis. Next we discuss a topic called as small molecules in dermatology. Now these are molecules which have a less molecular weight. That's why we are able to give it orally and they inhibit certain signaling pathways in the cell. So two important drugs to remember. Number one is phosphodiesterase 4 inhibitor, which is Mbbs. And the second important drug here is the JAK inhibitors. So in JAK inhibitors we have a drug called tofacitinib. Tofacitinib has already got FDA approval for psoriatic arthritis. So it is a JAK1 and JAK3 inhibitor. So this Janus kinase and STAT pathway, which we learn in pharmacology, 1 and 3 isoforms are inhibited by tofacitinib, and phosphodiesterase 4 inhibitor is epinelast. We now want to the second papillosquamous disorder, which is lichen planus. Now, lichen planus is defined as a chronic immune-mediated inflammatory disease, which not only involves the skin, it also can involve the hair, mucosa, and the nails. The most common trigger for lichen planus is what we can identify it. We call it as dental amalgam. Dental amalgam, which is made up of mercury. It is made up of mercury. And now, look at the cutaneous features of lichen planus. There are 6 P's, you need to remember. So you have purple and pruritic, polygonal and plain dot, papules and plaques. So very, very important. First, we remember the color and the symptom together. Next, we remember the shape. Most common trigger for lichen immune-mediated inflammatory disease, which not only involves the skin, it also can involve the hair, mucosa, and the nails. The most common trigger for lichen planus is what we can identify it. We call it as dental amalgam. Dental amalgam, which is made up of mercury. It is made up of mercury. And now, look at the cutaneous features of lichen planus. There are 6 P's, you need to remember. So you have purple and pruritic, polygonal and plain dot, papules and plaques. So very, very important. First, we remember the color and the symptom together. Next, we remember the shape. Look at it. Trigger for lichen planus is what we can identify it. We call it as dental amalgam. Dental amalgam, which is made up of mercury. And the symptom together. Next, we remember the shape together. Then we remember the morphology together. So it's very important that we remember things in a particular way. So color and symptom together, purple and pruritic. So you can see this purple pruritic lesions. Polygonal and plain dot is talking about the surface and the shape. Plaques is basically the morphology of the lesion. Now, when you look at the surface of the lichen planus lesion, especially if you see with a magnifying lens, you will be able to see a reticulate pattern of the skin. So you can see a reticulate means a net-like pattern. With a net-like pattern of the skin. This is referred to as Wickham's striae. This is referred to as Wickham's striae. Very, very important point in the context of lichen planus. And then please remember the distribution of lichen planus. And I talked about psoriasis, it was extensorial distribution. Lichen planus is flexorial distribution. So that is one thing you need to remember. And the same phenomenon which was there in psoriasis, in lichen planus also, which was true cognus phenomenon. After examining the skin, let's look at the oral cavity. The oral cavity lesions are seen in 40 to 60% of the patients with lichen planus. The pattern that we get here is very similar to the skin lesion. You get reticulate, lacy white pattern. Reticulate, lacy white pattern. On examination of the oral cavity, we see only 40 to 60% of the patients. After you look into the mouth, you look at the nail examination. When you look at the nail examination, the most common nail change to see in lichen planus is referred to as thinning of the nail plate. So this is the most common. Please remember, in psoriasis, the most common was pitting. In lichen planus, it is going to be thinning, and the most characteristic nail change is this one. So you can see a wing-shaped fold like this. Let's see, it is extending from the proximal nail fold onto the nail bed. This triangular wing-shaped fold from the proximal nail fold going into the nail bed. So this is referred to as pterygium of the nail. This is very, very characteristic. So please once again remember this one.
Pterygium is
Most common is
lichen
the most
planus,
characteristic is
thinning
pterygium.
of nail
And lichen
plate.
planus involves the hair. We call it as lichen planopilaris. The word pilaris means hair. And it is going to be producing scarring alopecia. Now it is about the histopathology of lichen planus. In histopathology of lichen planus, number 1, what you need to remember here is the stratum granulosum. So you can see clearly this is the stratum granulosum here. So you can see that the stratum granulosum is thickened, and this shape is called wedge-shaped hypergranulosis. Very, very important. This is the wedge-shaped hypergranulosis. This is point number 1. Now point number 2 is you look at the retail ridges. So when you look at the retail ridges, you can see that it resembles a sawtooth. So I've already highlighted it. Highlighting again. This is the downward elongation of the epidermis. It is called retail ridges. So this is resembling a sawtooth. That's why we call it as sawtoothing of the retail ridges. Sawtooth is the appearance of the retail ridges here. Going further, at the junction of the epidermis and dermis, we see a cleft, and this cleft at the dermoepidermal junction is called Max Joseph space. Max Joseph space. And one more important thing is you can see this inflammatory infiltrate over here, which is in the form of a band-like lymphocytic infiltrate at the dermoepidermal junction. This inflammatory infiltrate is band-like in pattern. And then what do we see here? We can see these eosinophilic bodies over here. So these eosinophilic necrotic keratinocyte representing bodies, these are referred to as colloid bodies, also referred to as civet bodies. Colloid bodies or civet bodies are the characteristic feature of lichen planus as well. Moving on to treatment of lichen planus, it is mainly steroids. So if there is a localized disease or a limited disease, we can give topical steroids. For extensive disease, we have to give systemic steroids. We now move on to the third important papillosquamous disorder, which is pityriasis rosea. Pityriasis rosea is defined as an acute self-limiting papillosquamous eruption. So usually when we use the word eruption, it is triggered by infections. And what is the meaning of the word pityriasis rosea? So pityriasis means scaling. Rosea means red color eruption. So pityriasis, always remember students, the meaning of the word pityriasis is scaling. Rosea means rose-like. So etiologically, it is HHV7, which is the most common virus which can trigger it. It is now known to the clinical features. Clinical features, the first lesion to appear in pityriasis rosea is called as red patch also referred to as mother patch.
Gerald's
The
patch.
scales in
Gerald's
Pityriasis
patch.
rosea, they resemble collar of a neck. That's why they are also known as collarette of scales. And if you look at the distribution pattern, you get multiple skin lesions like this. They are distributed along the lines of Langer. They are distributed along the lines of Langer. You can see that they are parallel to the ribs. And this pattern is referred to as Christmas tree pattern. This pattern is referred to as Christmas tree pattern. So 3 MCQs in Pityriasis rosea. Number 1, the first lesion is called as Gerald patch. The name of the scale is collarette of scale, and the distribution pattern is called as Christmas tree distribution. We now move on to the last topic of papillosquamous disorder, which is called Pityriasis rubra pilaris. Now PRP is defined as a chronic inflammatory papillosquamous disease. Pityriasis means scaling, rubra means red, pilaris means hair follicle. So we have understood that it's basically a hair follicle kind of a disease that we are expecting. So here we can see the multiple follicular papules which are seen. These are also known as nutmeg greater papules. Nutmeg greater papules, which you see here. And then what you see is almost more than 90% of the body we can see is becoming red, and then we call it as erythroderma. And though we use the word erythroderma here, we can see that there are characteristic islands which are spared here. You can see these islands of sparing. So if the question comes in the exam, erythroderma with islands of sparing, straight away mark your answer as PRP, which is Pityriasis rubra pilaris. This was a question of this year's BPG examination. We now move on to the histopathology of PRP. In PRP, what happens is we get parakeratosis, orthokeratosis, parakeratosis, orthokeratosis. Now, this is arranged both horizontally as well as vertically. You get these tiers of parakeratosis as well as orthokeratosis. This pattern is referred to as checkerboard pattern. This pattern is referred to as checkerboard pattern. It is alternating horizontal and vertical. Keratosis and parakeratosis. We can see the histopathology of PRP here. So we can see some nuclei here which are representing parakeratosis, the nucleated stratum corneum, and few areas we can see are representing the normal keratinization, which we call orthokeratosis. So orthokeratosis and parakeratosis are alternating. This is called as checkerboard pattern. We now move on to the next topic in this chapter, which is going to be histamine-related disorders. Here, the first important disease to remember is urticaria. Now, urticaria is characterized by dermal edema. And here you can see the characteristic lesion of urticaria, which is referred to as wheals. In the context of wheel, we should remember that it's an itchy, transient plaque. Very, very important, students. This is called as transient. Transient means temporary. It comes, it goes, then again it comes, it goes at different parts of the body. That's why it's called as transient. You see there is central pallor and peripheral edema. Central pallor and peripheral edema. So, center shows pallor, periphery shows erythema. It's an itchy lesion which comes and goes. So that's the description of a wheel. There is a sign that we want to elicit in urticaria on a regular basis. We call it as dermatographism. So, dermo means skin. Graphy means to write. Let us now go to the demonstration of dermographism. So here what we do is we take a blunt object and we stroke the normal skin of the patient. So we can see we're stroking the normal skin of the patient over here. And then normally what happens, there is no response which is seen. In urticaria what happens, you get an exaggerated wheel flare response. So you can see this exaggerated wheel flare response in this patient. So this means there is a positive dermatographism. Now what is the treatment of chronic spontaneous urticaria? Now when I use the word chronic urticaria, that means it is more than 6 weeks. When I use the word spontaneous urticaria, that means there is no identifiable trigger. There is no identifiable trigger. So some individuals get wheals without any reason. So what do we do about it? First, what we do is we give second generation antihistaminics like loratadine,
cetrazine, fexofenadine.
So these are some so-called non-sedative antihistamines. Do we know that cetrazine does produce sedation in some individuals? Next, what we can do is the guidelines now mention we can use an anti-IgA monoclonal antibody, which is omalizumab. Rituximab, I've mentioned as anti-CD20. Here it is omalizumab. And then we can also use calcineurin inhibitors like cyclosporine. Now, what do I mean by angioedema? So please remember, students, urticaria is dermal edema, angioedema is subcutaneous or submucosal edema. So here, this is subcutaneous.
Angioedema, remember side effects of ACE inhibitors?
It's much deeper than urticaria. Why is it called angioedema? Angio means blood vessel. It is characterized by increased vascular permeability. So once this increased vascular permeability, what is going to happen? There is a fluid accumulation in the affected areas.
Can I go
fluid accumulation in the affected areas? The more common areas for angioedema are lips and eyelid are the more common sites for angioedema. Next, we want to talk about cutaneous mastocytosis. Now, cutaneous mastocytosis is also called as urticaria pigmentosis. This is point number 1. What is the pathology over here? So, cutaneous mastocytosis means in the skin. Cutaneous means skin. Mastocytosis means mast cell proliferation. So, here the skin lesion is showing mast cell proliferation. And generally, when mast cells proliferate in the skin, you get hyperpigmented lesions. Hyperpigmented skin lesions. And one question in pathology is very important is how do you demonstrate these muscles? By a tolerating blue stain. So the name of the stain is tolerating blue. And one more point you need to remember for a pathology exam, tolerating blue stain. metachromatic granules. Metachromatic granules. Now, here we see the clinical picture of a patient with mastocytosis in the skin. So you can see these multiple hyperpigmented lesions, and what the examiner does is he scratches the hyperpigmented lesions. Now, please remember, students, in dermographism, you're stroking the normal skin, whereas in this sign, you're demonstrating it on the lesional skin. So what happens is when you stroke the lesion of mastocytosis, what's going to happen? The mast cells will get degranulated. So mast cells degranulate. There is a release of histamine, and histamine produces erythema with a vertical halo. This clinical sign is called as Darier's sign.
Darier's
So
sign.
please remember this point that
Erythema
Darier's
plus
sign is
vertical halo
elicited over
stretch.
lesional skin. Dermographism is elicited in the area over normal skin. This is a very fundamental difference that we need to remember in weight. Now we understand the name of the sign is Daria, and why this condition is called cutaneous mastocytosis is also called as urticaria pigmentosa, because the lesions are pigmented. When you scratch the pigmented lesions with urticaria, that's why it's called as urticaria pigmentosa. We now move on to the next topic of hereditary angioedema, which is the autosomal dominant disorder. It involves the complement system, and the defect here is in C1 esterase inhibitor. And here, how does the patient present recurring episodes of non-pitting edema? So recurring episodes of non-pitting edema with no veins. Then think of hereditary angioedema. We move on to the next topic of eczema, which is defined as a reaction pattern of the skin. We can have acute, subacute, and chronic. In acute eczema, we have erythema, edema, vesicles, oozing, and crusting. So you can see all the acute signs of inflammation. There are oozy lesions, there are edematous areas, there are
vesicles,
vesicles.
oozing,
So together, all
crusting,
these acute inflammation
ocular
is
vesicles.
Next, we move on to chronic eczema. In chronic eczema, what happens? Any portion of the skin, if you continue to scratch, what happens? It will create hot changes. Together, it is referred to as like inflammation. So here, you see the image, you can see point number 1, the skin has become darker, that's called hyperpigmentation. We can also observe that the skin is thicker, it's thickening of the skin. And lastly, we get exaggerated skin markings. Hyperpigmentation, thickening of the skin, exaggerated skin markings are there. Together, it's called as magnification. Let us now move on to the etiological classification of eczema. We have two important forms, exogenous and endogenous. Let's take up exogenous eczema. The first one here is contact dermatitis. Now, contact dermatitis is a type of eczema which happens to contact the substance. So here we have irritant contact dermatitis and allergic contact dermatitis. Now, irritant contact dermatitis, we can remember the example of acids and alkalis.
Acids
Take this example in your mind.
and
So here, irritant contact dermatitis is seen in all who are exposed. That means if acid falls on everybody's hand, it will burn, isn't it? Whereas we look at allergic contact dermatitis, it's seen in genetically predisposed. Now, cement allergy, metal allergy, all these allergies are seen only in selected people. Now, why does it happen like that? That is because in irritant contact dermatitis, there is different tissue damage. That means the acid will directly damage your skin. So it is non-immunological. So it's non-immunological. Allergic contact dermatitis is immunological. It's an example for type 4 hypersensitivity reaction. And please remember, if an acid or alkali falls on your hand, only the area of the skin where it is causing damage, that means it is restricted to the site of contact. Whereas in allergic contact dermatitis, if you use hair dye for that matter, not only the scalp is involved, the facial swelling also can be there. It tends to disseminate beyond the site of contact. It tends to disseminate beyond the site of contact. So there are three important differences between irritant and allergic contact dermatitis. Now here, as I mentioned to you, acids, alkalis, and detergents are common. Irritant contact dermatitis. One more important example to remember here is hyperdermatitis. So please keep this in mind, students. Hyperdermatitis is an example for your irritant contact dermatitis. We have to remember the examples of allergic contact dermatitis. Number one, the most common method producing allergic skin.
I have to go. Sorry guys. It's just 10 minutes, but I can control. Bye bye.